Pulse oximetry provides continuous, non-invasive monitoring of oxygen saturation using absorption spectroscopy to differentiate oxygenated from deoxygenated hemoglobin. The probe emits two wavelengths of light that pass through pulsatile tissue, and the ratio of absorbed light is converted into oxygen saturation. Probe placement determines whether the reading reflects preductal or postductal blood. The right hand measures preductal oxygenation, representing blood flow before the ductus arteriosus, while a lower saturation in the foot indicates postductal desaturation and possible right-to-left shunting, such as in persistent pulmonary hypertension or ductal-dependent heart disease. Pulse oximetry responds rapidly to changes in oxygenation and is reliable for detecting desaturation events. However, several factors affect accuracy. Motion artifact, low perfusion, anemia, and abnormal hemoglobins such as methemoglobin or carboxyhemoglobin can cause misleading readings. Bright lights or poor sensor contact may also distort results. Understanding these principles allows accurate interpretation of saturation trends and correlation with arterial or transcutaneous oxygen values. Continuous monitoring ensures early recognition of hypoxemia and supports timely adjustments in oxygen delivery or ventilator settings. Pulse oximetry is highly sensitive for detecting hypoxemia, but cannot distinguish between normal and excessive oxygen levels. An oxygen content of 100 and 250 both display as 100% saturation, making the monitor unreliable for identifying hyperoxemia. For this reason, oxygen titration should always be guided by defined saturation targets and not by appearance alone. Most pulse oximeters are not calibrated for saturations below 80%, and their accuracy has a typical variability of about 4%. Readings can therefore fluctuate even in stable infants. The right hand remains the preferred preductal monitoring site, while the foot represents postductal blood flow and helps detect shunting when the difference exceeds 5 to 10%. Historical practice shifted dramatically as both liberal and restrictive oxygen strategies produced harm. High oxygen exposure contributed to retinopathy of prematurity and oxidative lung injury, whereas overly tight restriction increased mortality and necrotizing enterocolitis. The NeOProM meta-analysis comparing target ranges confirmed these trade-offs. Saturations of 85 to 89% reduced chronic lung disease but increased mortality and NEC, while 91 to 95% improved survival but raised the risk of retinopathy. Consensus target range for most preterm infants is now 90 to 94%, with alarm limits set between 89 and 95% to minimize time spent outside the therapeutic window. Maintaining oxygen saturation within the target range depends on both technology and staff response. Narrowing alarm limits improves time and range because even small deviations trigger early intervention. However, this approach also increases the number of audible alarms, which can contribute to alarm fatigue and staff desensitization if not carefully managed. Sound intensity is another consideration. Although recommended to remain below 45 decibels, many monitor alarms exceed 100, which can startle infants, increase heart rate, and raise oxygen consumption. Adjusting volume, using visual cues, and clustering responses can reduce physiologic stress while keeping alarms effective. Strict compliance with alarm management is essential. Silencing or widening limits to reduce noise defeats their purpose and delays recognition of true desaturation events. Consistent adherence supports safe oxygenation and reduces episodes of both hypoxemia and hyperoxemia. Automated systems that titrate inspired oxygen based on continuous saturation feedback are emerging as valuable tools. They can reduce caregiver workload, shorten the duration of off-target saturations, and maintain more stable oxygen delivery when used alongside vigilant clinical oversight. Transcutaneous monitoring provides continuous, non-invasive assessment of ventilation and oxygenation by measuring the partial pressures of carbon dioxide, and in some devices, oxygen through heated skin sensors. The heating element increases local capillary blood flow, allowing gases to diffuse through the skin to the electrode for analysis. The primary parameter used is transcutaneous carbon dioxide, which correlates closely with arterial carbon dioxide when perfusion is stable. Some sensors also measure transcutaneous oxygen, although these values are more variable and require periodic correlation with arterial gases. Transcutaneous monitoring is most useful when frequent blood sampling is undesirable or arterial access is not available. It provides valuable trend data for infants on mechanical ventilation or those with evolving chronic lung disease. Limitations are significant and require consistent attention. The probe site must be heated, typically between 43 and 45 degrees Celsius, which increases the risk of thermal injury if the sensor remains in one place for too long. Sites must be rotated every 3 to 4 hours to prevent burns and ensure accuracy. Calibration drift occurs over time, making intermittent comparison with arterial samples essential. Accuracy decreases when perfusion is poor, such as during shock, hypothermia, or vasoconstriction, as gas diffusion becomes limited. Under these conditions, values can deviate substantially from arterial results, and reliance on transcutaneous readings alone may be misleading. Capnography provides additional information about ventilation and airway patency, but its utility in neonates is limited by small tidal volumes and airway leak. The first component is the colorimetric detector, used primarily in the delivery room. It confirms endotracheal tube placement by indicating the presence of exhaled carbon dioxide, but it is not a quantitative tool. The quantitative waveform is available through mainstream and side stream sensors. Mainstream monitoring measures exhaled gas directly at the airway interface and provides a rapid response time, but the sensor adds dead space, which is significant in extremely small infants. Side stream monitoring aspirates a small amount of gas into the analyzer. In neonates with very small tidal volumes, that sampling may remove a meaningful portion of each breath, reducing accuracy and at times altering the delivered volume. Limitations are most pronounced when tidal volumes are low or when uncuffed endotracheal tubes allow substantial leak. Both conditions reduce signal strength and lead to underestimation of carbon dioxide content. The best application is trend monitoring. Consistent waveform presence confirms airway patency and helps detect tube dislodgement or apnea. Capnography supplements blood gas analysis, but cannot replace it in neonatal practice because of the inherent technical constraints. Accurate respiratory assessment depends on integrating multiple monitoring tools rather than relying on any single measurement. Each method provides a different perspective on gas exchange, and correlation among them ensures reliable interpretation. For oxygenation, arterial blood gas remains the definitive standard because it measures actual oxygen tension. Pulse oximetry provides continuous trend data but cannot detect hyperoxemia once saturation reaches 100%. Transcutaneous oxygen monitoring offers continuous values but must be regularly correlated with arterial samples to correct for calibration drift or perfusion changes. For ventilation, arterial carbon dioxide remains the reference standard. Transcutaneous carbon dioxide monitoring provides reliable trending when perfusion is stable, allowing early recognition of gradual changes between blood gases. End-tidal carbon dioxide reflects exhaled gas, but is less accurate in neonates with small tidal volumes or airway leak. However, consistent waveform trends still indicate airway patency and adequacy of ventilation. Clinical decisions should always integrate these data sources with the infant's overall status. When all monitoring methods trend in the same direction, the interpretation is likely accurate. Discrepancies between modalities signal the need to verify perfusion, probe placement, or sampling technique before making ventilator adjustments. Reducing cumulative blood loss is a critical part of respiratory management in fragile infants. Each blood gas or laboratory test removes a small but meaningful volume, and repeated sampling over days can amount to significant iatrogenic anemia that requires transfusion. Every sample should be clinically justified. Before ordering a test, the team should ask whether the result will change management today. Routine or automatic daily blood gases in stable infants add risk without benefit. Once ventilator settings and oxygen needs are stable, continuous monitoring with pulse oximetry or transcutaneous carbon dioxide often provides the same information without additional blood loss. Reviewing prior gases and recent ventilator or FiO₂ trends before requesting another sample avoids unnecessary testing. Many questions about ventilation or oxygenation can be answered by examining those existing data. Coordinating timing of lab draws also conserves volume. Combining chemistry, hematology, and blood gas sampling into a single collection and aligning draws with line access or morning rounds limits total frequency of puncture and manipulation. Excessive sampling can remove up to 10% of an infant's circulating volume in a week, directly contributing to transfusion exposure and instability. Laboratory testing should therefore be targeted, coordinated, and always linked to a clear clinical purpose. Microvolume laboratory methods allow accurate testing from very small samples and should be used whenever possible. Confirm the true minimum volume required for analysis with the laboratory. Most gas and chemistry assays can be performed on less than 0.3 milliliters. Capillary sampling can replace arterial draws when only pH and carbon dioxide content information is needed and perfusion is adequate. This approach reduces blood loss and frequency of invasive line access without compromising respiratory assessment. Workflow integration is another important strategy. Clustering laboratory testing with other procedures, such as line access or medication checks, minimizes repeated handling and blood exposure. Communication between nursing, respiratory therapy, and the medical team prevents duplicate or unnecessary tests. Point-of-care analyzers further reduce waste by providing rapid results at the bedside using microvolume samples. When combined with non-invasive monitors such as pulse oximetry, transcutaneous carbon dioxide, or near-infrared spectroscopy, they allow continuous trend monitoring without repeated sampling. Tracking cumulative blood loss in milliliters per kilogram each week helps teams visualize the impact of testing. Reinforcing a one-sample, one-purpose approach during rounds promotes a culture of conservation and helps maintain hematologic stability in extremely preterm infants.